Hello, I'm Paul St. John, founder and director of the St. John Calandro Clinical Institute of Neuromuscular Therapy and founder of the St. John Method of Neuromuscular Therapy. The purpose of this presentation is to give you a clear understanding of what the parameters of neuromuscular therapy are, the philosophy of neuromuscular therapy, and its application to human pain and suffering. In order to understand the evolvement of this work, I think it's necessary to know a little bit about myself, about the professional involvement in the field of massage therapy that I've undertaken, and the reason that I've explored the parameters of pain in relationship to soft tissue involvement. And the reasons are basically that I was in pain. And I've been in pain rather severely 3 times in my life. First being playing high school football. I broke my back in 3 places. Secondly, I was injured quite seriously in Vietnam and hurt my back again. And finally, about 17 years ago, I was in a very severe car accident where a drunk went through a red light going 60 miles an hour and I was going 30 miles an hour. And that incident left me in unceasing pain for about 4 years. During that period of time, I began exploring the reasons that I was in pain, because after spending many thousands of dollars and receiving very little help, I was frustrated and I was fearful about my future. But during that period of time, I spent a lot of time at medical libraries researching pain mechanisms, and much to my surprise, a lot of information I found was related to the soft tissues of the body: muscles, tendons, ligaments, fascia, and aponeurotic tissue. And as a result of that research, I began looking into the physical manipulation of soft tissues as a way of relieving myself, and initially began teaching other people to treat myself. Out of that experience evolved the science of neuromuscular therapy and my own involvement as a national and international teacher. So in order to understand this involvement, I want to just share with you our definition of neuromuscular therapy, because after all, the word neuromuscular therapy can just be a word unless it means something. What it means to us in our definition is that neuromuscular therapy is the science by which homeostasis is brought about between the nervous system and the musculoskeletal system. Now, the word homeostasis means normal physiological functioning. So what we're trying to obtain here is normal functioning between the nervous system and the musculoskeletal system. In order to do that, we have to explore physiological principles or laws by which the human body works. I began exploring these laws in an attempt to find out why I had constant and chronic headaches for a 4-year period. As a result of looking into some of the laws that we're going to explore in this program and their utilization, how do these laws work? How do they affect the performance of human beings in their normal everyday life as well as athletes? I have been employed by the Indiana Pacers of the National Basketball Association, for example. We've applied these laws and principles there. I've been teaching neuromuscular therapy since 1978 and have been awarded by the Florida Massage Therapy Association in 1987 the award of Therapist of the Year. And all these experiences have brought about the evolution of this work in order to present to humanity a viable science that is both valuable, should be economically feasible, and something that I think everyone on the planet should know about. And the application of the knowledge that we're going to present should be that people have a viable healthcare alternative here. They have a choice in managing their own pain and the treatment of their own pain, and know something about pain mechanisms. So without further ado, let's look at some of the physiological laws and conditions that govern the vast majority of human pain. The first principle that we want to talk about that makes up the four physiological principles upon which neuromuscular therapy is based is the principle of ischemia. The word ischemia, I-S-C-H-E-M-I-A, literally means a lack of blood. Now, the chief characteristic of an ischemic tissue is its hypersensitivity. For example, if you're in pain and you're grasping constantly your shoulders and your neck, if you touch tissues of your body with 5 to 10 pounds of pressure, there should be no tenderness at all. But if the tissues are tender, those tissues are ischemic. They're in a hypercontracted state, they're extremely sensitive, and they're receiving very poor blood supply. So one of the first things that we analyze in the science of neuromuscular therapy is whether tissues are ischemic or not. The second physiological principle upon which neuromuscular therapy is based is that of trigger points. Now, there are many researchers in the field who refer to trigger points as myofascial trigger points, meaning that trigger points exist in muscle and fascia tissue. We think that this is a misnomer because trigger points can be found in all the soft tissues of the body, as well as generating from internal organs and, on occasion, bones. So we want to give you our definition of trigger points because it varies from a lot of researchers in the field of pain and pain control. A trigger point is an area of high neurological activity. Now, high neurological activity means that nerve receptors are firing at a very fast rate of speed. So a trigger point is an area of high neurological activity that causes secondary referrals and pain patterns. Now, those secondary referrals and pain patterns can feel like tingling, burning, numbing, thermal sensations, such as trigger points can cause heat sensations in the body or cold sensations in the body. Most people who have trigger points are unaware that they're there. Most trigger points are silent until they're palpated by a healthcare practitioner. For you to understand trigger points, let's go to our trigger point chart, and I want to point out some common pain patterns that exist in human beings. For example, this muscle right here, the sternocleidomastoid, this common muscle in the neck, it has two heads, an anterior head that attaches on the sternum and a posterior head that attaches on the clavicle. Trigger points in the sternal head commonly cause this arcing pain above the eye and in the eye. This is the classic migraine arc, if you will. It also will cause headaches and pain patterns in the back of the head. The clavicular head, the head that attaches on the clavicle, often refers pain around the ear and in the ear and in the frontal lobe of the cranium. Now, what we should realize about trigger points is that, one, their referred zones are always ischemic, the first principle that we talked about. For example, if the trigger point exists in the muscle, if it is firing in the eye and around the eye, it's causing the eye to have less circulation. It's very important to understand. In order for you to dramatically understand the potential of trigger points to cause disease and pain, I want to share with you a clinical case history of a woman who came into our clinic about 8 years ago. This woman had been in a car accident, and she was the wife of a minister, a former patient that I had successfully treated for back pain. And her husband had referred her to the clinic because she was having severe headaches and chest pain. When I came into the examining room, she was sitting on the examining table with a gown on, with her hands crossed in front of her. As we began to talk, I asked her about her symptoms. She told me about her headaches, about her chest pain, and I asked her if she was in a lot of pain in her chest at that point in time, and she said no. So I asked her to lie down on the table, and as she lied down on the table, she kept her arms across her chest. I thought this odd at the time, since she said her chest was not in any particular pain. So I asked her to set up, and I said, look, it's very essential that our relationship between therapists and you as an injured person be honest. Why are you holding your chest like that? She replied, frankly, I'm embarrassed. I have a condition called fibrocystic disease, and since my accident, it's gotten a lot worse. I said, that's quite explainable, understanding the functioning of trigger points. She said it is, and she was in quite a surprise about that. And I said, yes, it's often occurs when women have fibrocystic disease, that the condition becomes exacerbated and excited and becomes worse because of the increased neurological activity caused by pain and referred pain. She became relaxed and put her arms down, and she said, well, quite frankly, I'm embarrassed. And what I could see on her gown was little tiny spots of blood. And she explained to me that since her accident, she had experienced multiple eruptions in her breast. I explained to her that there were three muscles that commonly refer pain into the breast. One is the pectoralis minor in the upper chest, the pectoralis major, and the serratus anterior. We examined those muscles, and sure enough, there were trigger points harbored in those muscles that referred pain into her breast. Now, there's several neurological laws that are important to understand. I want to mention the first law so that we can have an understanding of how pain mechanisms work in the body, and that law is the Arndt-Schultz law. And the Arndt-Schultz law says, weak stimuli activate physiological processes, strong stimuli inhibit them. What that means is that the body works on an amazing economy of energy. And when nerve endings are firing at a very low rhythmic rate of speed, those types of impulses regulate human physiology and make it efficient. When there is injury or trauma or stress, nerve receptors fire at a very rapid rate of speed, and those rapid impulses inhibit physiology. What was literally happening in this woman was that the intense impulses coming from trigger points in her damaged chest muscles were firing or referring pain impulses into her breast, inhibiting the physiological functioning of her breast. The result was eruptions and poor health of those tissues. We treated those muscles, and within several weeks, the condition that she was experiencing completely cleared up and has stayed cleared up for 8 years. So it's our belief that probably these trigger points existed before her initial accident. Now let's look at some other trigger point patterns on the chart here. So you can see, for example, how trigger points in muscles in the neck, at the base of the skull, have common pain patterns in the head. For example, these muscles, called the suboccipital muscles, commonly refer pain around the ear and the side of the head. This muscle here, the trapezius, this common large muscle that extends from our neck to our shoulder down to the middle of our back, can refer pain patterns behind the eye, in the base of the skull, and into the jaw. Some of the common trigger points in the jaw muscles, for example, can refer pain patterns over the eye and into the ear. What we see from these pain patterns that are on this trigger point chart is that pain can be referred from many parts of the body. The cause of pain can actually be far removed from the experience of the pain. You can have trigger points, for example, in the sternocleidomastoid that are causing headache patterns in the top of the head. So far we've talked about two physiological principles that the science of neuromuscular therapy is based upon. First is the physiological principle of ischemia, which means hypercontracted tissue, hypersensitive tissue that is experiencing a lack of blood. The second is trigger points, and we explained what they do and how they cause pain. The third is the principle of nerve entrapment and/or nerve compression. Now, to understand nerve compression, let's go to the skeleton and look at how these nerves leave the spinal column. You see here is the spinal column, and these are spinal nerves. These nerves are subject to intrusion if any one of these discs moves in a way that presses on the disc. Here at the bottom part of this spine, we have an example of what is called a ruptured or herniated disc, where one of these spinal discs has flattened and bulged, and the gelatinous material inside it has oozed out, causing this bulge or herniation, and is therefore pressing on this nerve, which would cause extreme pain down the leg and into the foot. This is what most people think of as a pinched nerve. Actually, it's classified as a compressed nerve. Now, the tissues that have the ability to compress nerves are bones and cartilaginous tissues, such as discs. Here we have a disc or a material that looks like a disc, and these discs can migrate or move in the human spinal column as a result of muscular constriction, poor postural patterns, overweight patterns that cause us to have arching backs, for example, which cause the vertebrae to rock back and pinch these discs or move them into the nerve root. So pain caused by this type of intrusion is called nerve compression. Let me give you another common example, and that would be in the neck area. A common cervical curve would look like this, for example, extending like this. The condition of military neck, where the person has lost some of their cervical curve, would look like this. And the condition of reverse cervical curve, where the actual curvature has reversed, would look like this. Now, this condition, or the condition of the military neck, is extremely dangerous because it causes the discs usually to move or migrate backwards into these nerve roots. What is not generally looked at with enough importance in our society is what structures take a normal cervical curve like this and cause it to be reversed like this. And those structures are muscles. Let me give you an example. When someone suddenly experiences a whiplash like that, which I did 17 years ago, there are literally thousands of pounds of pressure suddenly initiated on human tissue and structure. And when that process happens, it causes the ripping and tearing and tightening of tissues. And as those tissues tighten, they tighten for a reason, and mainly to stop the bleeding. Our nervous system initiates the tightening and the spasm. And within the first 24 to 72 hours, that spasm is there and has a very valid physiological reason for being there, and that is to stop the bleeding and cause our tissues to contract. But after the initial injury phase where the bleeding has stopped, there's no reason for that constriction to be there. Yet it may exist for years if improper examination of the soft tissues does not occur. It is not uncommon in our clinic where we see people who've been in pain for 5, 10 years, who not only are still in pain because they have constricted tissues, but they've never been touched where their tissues are in a hyperconstricted ischemic state. Understanding the role of soft tissue in nerve compression is important, because just treating a vertebrae, for example, that is moved posterior, by attempting to moving the vertebrae without treating the soft tissues that are actually responsible for moving the vertebrae, is the difference between treating effects and treating the cause. And if we treat the cause, we're going to be much more successful in our treatment. The person who's in pain is going to be in pain for a much shorter period of time. They're going to spend a lot less money. They're going to be a lot healthier and happier much more rapidly. So it's very important that in our system of analysis that we look and examine the relationship of cause and effect related to pain patterns. So the first principle that we're looking at with nerve compression is nerve compression caused by osseous structures, bones, and cartilaginous tissue. Nerve entrapment, on the other hand, is caused by the tightening of soft tissues that actually strangulate the muscles that or the nerves that permeate the muscle. Say, for example, I had a tight forearm muscle, and that muscle tightened far beyond what is normal. The nerve fibers permeating that muscle would suddenly be entrapped. There would be a physical constriction around those nerves. That is the most common type of pain, called nerve entrapment. And that nerve entrapment always causes ischemia, and usually, if it's left there long enough, will cause the formation of trigger points. So far we've talked about three physiological principles that cause pain. First, ischemia. Second, trigger points. And third, nerve entrapment and/or nerve compression. The next physiological principle that we want to talk about is that of postural distortion. And the reason postural distortion is so important is because every human being, sooner or later, is subjected to postural distortion because of the force of gravity on the human frame. Gravity imparts itself on human beings at the rate of 33.5 pounds of pressure per square inch. Think of your body for a minute, and every 1 square inch, there is a physical force imparting itself on your body at the rate of 33.5 pounds of pressure per square inch. Over the course of a lifetime, people can be literally compressed by the physical force of gravity, and are. Most of you know that people have a tendency to get shorter as they get older. And part of that is because of the forces of gravity. Now, human beings were designed to oppose gravity efficiently. It's our experience, though, that about 99% of the people walking around oppose gravity extremely inefficiently. Every living thing, it's our contention, was designed to oppose gravity efficiently, whether it be a mima or a giraffe or a human being. But many of the biological animals on this planet do not only experience gravity as a devastating force, but they oppose it inefficiently. To understand how this force can devastate human beings, let's look at the gravity lines and examined how human beings should oppose gravity efficiently. Now, these lines right here that you see in this anatomy chart represent the forces of gravity as they go through our body. This plane is called the mid-sagittal plane. And when human beings are opposing gravity efficiently in this plane, this is the way this line should go through our bodies. So let's look at this line that you see here and see what it bisects. First, this gravitational line would bisect the cranium, as you see here, through the nasal septum, the mandible. It would bisect each of the vertebrae and the sternum, the breastbone here, and the sacrum here, and the pubic symphysis. Now, this point right here, this little round circle that you see here, represents the center of gravity. Every living thing has a center of gravity, including human beings. In this chart, there are 3 areas where the center of gravity is illustrated. Here you see in a lateral or side view of the body that the center of gravity goes through the side of the pelvis. From the back view here, you see that the center of gravity goes through the bone called the sacrum. In a back view right here, and in a front view, the center of gravity is positioned here. From a side view, the center of gravity is called the coronal plane, and this gravitational line, as it goes through human beings, will give us a great deal of information about postural distortion, as will this line, but this line is much easier to analyze. For example, you can just look at someone and see if their head is tilted 10 degrees. But the coronal plane, as it's called, will give us much more information than the mid-sagittal plane, but it's also much more complex to understand. The first thing that we should note about the gravity line is that it bisects this suture juncture right here between the frontal and parietal sutures. Now, as we study the cranium, we will see that this is the last part of the suture to come together. It's known in babies as the soft spot or the fontanelle. And the design of this suture is quite different than the other sutures. And we'll talk about the reason for that a little later. But let's follow this gravity line down our physiologies, down our physical frame, and notice that it bisects one of the cranial bones called the temporal bone and the ear, the opening in the ear here called the external auditory meatus. So the gravity line actually, if we're in correct posture, should actually come down through our ear. Now, the next mark on the chart, the black line you see here, says the gravity line enters through the tip of the odontoid process. Now, the odontoid process is this bony protuberance that we see on the second cervical vertebrae. And I want to point it out because the second cervical vertebrae, as you can see, is designed completely different than any other vertebrae in the spinal column. You see this structure right here on the second cervical vertebrae is called the odontoid process, or the dens. This is the structure where rotation in the neck takes place, around this structure. So you can see as the cranium rotates, it rotates around the odontoid process. Now, in studying human physiology, and in studying the importance of C2, it reminded me in its function of that of a top. Have you ever taken a top and spun a top? And when that top is opposing gravity, where's it pointed? Well, it's pointed directly upward, isn't it? And when that top starts to oppose gravity inefficiently, what will happen is that it will start to wobble and become very inefficient in its movements. Exactly the same thing happens in human beings. When the gravitational forces are not aligned on this tip of the odontoid process, people start to wobble. They have gait patterns in which they take a step and they walk like this. They waddle from side to side. They also have gait patterns in which from the side they bob their head as they walk. They walk like this. These are all torquing gravitational forces that are produced, that produce physical discomfort and harm to the human frame. Everything that moves produces a physical force called momentum. The formula for momentum is mass times velocity equals momentum. Now, it's important to understand that as we produce momentum in the physical body, our body has also been designed to dissipate momentum. Where human beings should dissipate momentum is through their upper extremities by swinging their arms in a cross-pattern movement. You will oftentimes see people who are in pain who barely move their arms or don't move them at all. So therefore, this physical force called momentum is then not only dissipated through their extremities, but it's internalized in their body. And this force can be devastating in terms of musculoskeletal pain and degeneration of the skeletal system itself. Now let's go back to this mid-sagittal plane again, because we've determined that if gravity is opposed efficiently, the gravity line should go through the tip of the odontoid process. As we follow this gravity line down, notice that in each of the 7 cervical vertebrae, the gravity line bisects the cervical vertebrae. So what that means is that the cranium, which comprises 1/10 of the body weight, should be held up by the cervical spine. But what is holding up the cranium in most human beings is not the cervical spine, but the posterior muscles of the neck, these muscles in the back of the neck, and this ligamentum nuchae, this ligament in the back of the neck. These are the structures that are holding up the neck. And the reason that is occurring is because most people's head are forward of where it should be. 99 out of 100 people, their heads will be tilted forward, like so. And then what happens to this gravity line is that the gravity line goes what is called posterior or behind the structure. When this happens, there's a whole series of compensations that take place in human physiology. One is, as the head goes forward, it will start to rotate backward so that we maintain our balance. So no matter how far your head goes forward, it will be a priority of your body to keep you looking level, to keep your balance. Now, I'm sure we've all had the experience of seeing old people walk around, barely able to walk, and we can see the effects of gravity compressing them. But what we should realize is the moment that human beings move off this center gravity line called the coronal plane, several things start to occur. One is their soft tissues start to tighten and compensate for moving off the bony skeletal structures. The second is that our nervous system starts to fire more rapidly and becomes excited as our soft tissues are asked to constrict and tighten. Those processes can cause energy drains over a long period of time, can cause the inefficient use of energy in the body, and can cause deterioration of our joints and discs. Now notice down here the second dark line on this chart says the gravity line emerges from the body of the 7th cervical vertebrae. So after the 7th cervical vertebrae on the coronal plane, the spine does not have a primary weight-bearing function. On the mid-sagittal plane, though, the spine always has a primary weight-bearing function, but not on the mid-sagittal plane, or excuse me, on the coronal plane. Now, as we come down further, there should be another black line right here, which says that the gravity line bisects the transverse axis of the shoulder joint. And what that means, literally, is that our ear should be over our shoulder, or our head should be on our shoulders, literally speaking. As we descend down the coronal plane, the next line that Dr. Bachin has put on this chart says the gravity line enters the body of the first lumbar vertebrae. So at the level of our lumbar spine, and here is an illustration of our lumbar spine, or a model of our lumbar spine. At this point, the gravity line enters through the tip of the lumbar vertebrae, and it descends down the lumbar vertebrae until we get to this next line here, which says the gravity line emerges from the promontory. The word promontory is a Latin word which means shelf, and the shelf being spoken of is this shelf of the sacrum. So from the first lumbar vertebrae to the shelf of the sacrum, at this level of weight bearing in our bodies, the lumbar spine should bear weight and have a primary function both in the mid-sagittal and coronal plane of weight bearing. And what should hold us up at this level are these vertebrae. But again, what happens with most people, as gravity pushes us forward and we become more inefficient in opposing gravity, is that we start to move forward. And again, this gravity line, which we see here, will move backwards. So what starts to hold us up instead of these vertebral bodies is this ligament in the low back called a supraspinous ligament and the muscles of the low back, the muscles in the back, now start to assume a primary weight-bearing function. Now, once that happens in the low back or anywhere, we should understand that there's a physical change in the muscle fibers that takes place. Whenever muscles or any soft tissues assume the physiology of bones, that is, their primary function becomes bearing weight instead of creating movement, which is the function of muscles. The function of muscles is to create movement. For example, the bones in this finger are moving because muscles are moving them. It is the constriction of these muscles that makes the bone move. It is the primary role of muscles to create movement and not be utilized as structural function. But what happens when we have postural distortion in the human body, as we've talked about? The head moves forward, so what holds us up? The muscles of our posterior neck. As we move more off the coronal plane, what holds us up at the level of our back is the low back muscles instead of the vertebrae of the low back. So what the muscles do then is become thicker, harder, and more denser to assume and mimic the physiology of bones. So let me restate that again. That whenever the soft tissues of the body, muscles, tendons, ligaments, and fascia, assume a primary weight-bearing function, they start to mimic the physiology of bones. It's essential that we understand that. Now, as we further descend down the coronal plane, we will come to this round circle called the center of gravity. Now, notice what we've said from the center of gravity up is that as the head moves forward, this gravity line then will move posterior like so. But this gravity line is always going to be a straight line, as you see here. But it will only be a straight line from the center of gravity up. As we go down our physiology, what this line will do is it will go in front of the center of gravity. Now let's look what happens, the compensations and the changes in movement that take place when our head goes forward or our pelvis rotates forward. One of the things that we should understand about the human body is as the head goes forward, what we do is start to rotate around our center of gravity, this point here in the pelvis. So as we rotate forward, our pelvis also tilts forward. So what we should understand about that process is it is a two-way street. If our pelvis rotates forward, notice that my head is going forward. It's not possible to keep your head over your shoulders if your pelvis rotates forward. What will happen is your head will automatically go forward if your pelvis rotates forward. Understanding that is essential to understanding human biomechanics. So we're going to refer to that process often in this course of study, and in the study of neuromuscular therapy, we're going to correct it. We're going to bring the head over the shoulder, and we're going to rotate the pelvis back by a process called pelvic stabilization, a process of stabilizing the pelvis. Because the pelvis is literally the foundation upon which all human structure in human beings is based. Here you see a pelvis, and this pelvis houses the center of gravity and is the basis upon which stabilization of the rest of our frame takes place. So if our pelvis is distorted, it's tilted to one side like this, or it's tilted forward or anteriorly like this, or posteriorly like this, notice that automatically the spinal column is going to compensate and move in different directions. And so will our head, and most of our body will follow suit. Whatever the pelvis does, it's going to influence the rest of our body. Just as whatever the head does at one end of our body, the rest of the body in some way will be affected. It's important for us to understand that. Now, as we examine the effects of postural distortion below the center of gravity, as a result of our head going forward and being influenced by gravity, and our pelvis rotating around the center of gravity, what happens is there's a whole series of compensations that take place in the lower body. For example, look what happens to my knees if my head goes forward. If my head goes forward, my knees go backward. If my pelvis rotates forward, my knees go back. That is an attempt to balance the body and keep the body on the straight coronal plane. But if that process happens, we should also understand what is happening to our joints and the structures below our center of gravity. So let's take a look at first what correct physiology is and correct physiological posture. Let's assume that the gravity line is going through the center of gravity and through these other structures where it should be. Below the center of gravity, what we see here in this, at the level of the hip joint, is that the gravity line bisects the transverse axis of the hip joint. So the hip joint should be a weight-bearing structure, and literally speaking, the hip joint should be over the shoulder joint, which should be over the ear. The cervical spine should be over the lumbar spine. As we descend down the coronal gravitational plane, we notice that the gravity line bisects the largest bone in the body, the femur. So at this level of weight bearing, what should hold us up is our femur. As we go down further, notice the next black line here says the gravity line bisects the transverse axis of the knee joint. So at this level of weight bearing, the level of the knee, what should hold us up is the knee joint itself. As we further descend down, notice that the gravity line bisects the shaft of the tibia, this large bone in the lower leg that we see here. So the entire shaft of this bone should be a weight-bearing structure. And finally, what we see here is that the gravity line bisects the transverse axis of the ankle joint, so that the ankle joint itself is a weight-bearing structure. Now, what we have here in correct physiology is a series of joints that should be stacked on top of each other to oppose gravity and bear weight efficiently. So we literally see that the ankle joint is underneath the knee. Or as we descend up this plane, we start with the ankle. The knee should be in line with the ankle. The hip should be in line with the knee and the ankle. The shoulder should be in line with the hip, the knee, and the ankle. But what we see, sadly, in about 99% of all people walking around, is that the joints are not stacked on top of each other. They're not aligned on top of each other. Take, for example, my knee. As my pelvis rotates forward or my head rotates forward, as gravity starts to press down on human physiology, my knees lock back. Now, what this will cause is a movement of the cartilage and the connective tissue in the joints that will literally shear those joints. Just like I'm moving my fist right now, those joints will start to shear and become misaligned. The connective tissue around the knees, for example, will become weakened. These various ligaments, the cartilage inside the knee and the ligament, the anterior cruciate ligament inside the knee, will start to conform to this postural distortion and be stretched and weakened. Now let's look at the effects of these joints and what will happen when the pelvis, for example, rotates anteriorly. As this pelvis, you see here, rotates anteriorly, what will happen is that the hip joint and this bone, the large bone, the femur, will rotate posteriorly. So what that looks like if I'm rotating my pelvis forward is that my knees lock back. The devastating result of this shift in human posture is that this bone will be positioned back here because the knees are locked back here. And so what will hold us up at this level of weight bearing instead of the largest bone in the body will be these muscles right here, the muscles in the front part of the upper leg, namely the quadricep muscles and the adductor muscles. Now, as we look at the adductor muscles, we will see that they attach around this point on the pelvis here, and the quadricep muscles, large muscles that extend our lower leg, attach around this point on the pelvis, the anterior superior iliac spine. Now, if we're looking at the pelvis from the side, and we wanted to pull this pelvis down or rotate it forward, we'd use one of these two leverage points, wouldn't we? It'd be very easy to take the pelvis and pull it down like this. Or it'd be very easy to take the pelvis and pull it down from here. That's exactly what nature does. Nature uses the muscle attachments here at the anterior superior iliac spine and at the pubic symphysis to rotate the pelvis forward. One of the major reasons for rotating forward and being moved forward off the coronal plane are tight muscles in the quadricep area. Now, some of the things that we do as human beings contribute to this rotating process. One of the things that women do is wear high heels. And when they wear high heels and they're in this position, that automatically tightens their quadricep muscles, tilts their pelvis forward, and the process of wearing high heels will exaggerate and even create low back pain and posterior neck pain. So we should understand that in the process of postural distortion, many, many structural changes take place. Circulatory changes take place as muscles tighten and constrict and cause the vessels within them to constrict. So there are whole areas of their body that get less circulation, that become tighter and tenser and more painful. Joints become weakened and stressed, and connective tissue starts to break down. As we go further down the body, we see that when the knees lock back, like so, what happens is this weight-bearing bone, the tibia, is also posterior back here, as is the femur. And so what gets loaded up, what holds our weight up, is not the shaft of this bone, but the muscles in the front part of our lower leg. These muscles right here. And those muscles are the anterior tibialis, the extensor digitorum, and the extensor hallucis longus. Now, all those muscles attach in the feet. So when the shaft of the tibia is no longer a weight-bearing structure, then what happens is these muscles that we've just mentioned and illustrated, and you've seen on the screen, start to tighten. The extensor hallucis longus, hallucis meaning great toe, attaches on the great toe. As it tightens, its attachment causes the great toe to shift medially. As it does that, it will cause the formation of a bunion in the foot. The extensor digitorum, the word digitorum meaning digits, attaches on all the toes. As it tightens, it will cause the toes to retract posteriorly and cause a condition of hammer toes. So what you will start to see as the human pelvis moves and becomes distorted, as the head goes forward, as we move off these gravitational planes, is that it affects the feet. Most foot problems, it is our experience, begin in the feet. Is that where doctors of the feet look for the problem? Do podiatrists look at the pelvis as the cause for foot problems? Not generally in our society at all. Yet the mechanism of pelvic rotation and postural distortion is irrevocably tied into the mechanisms of the feet. I hope with understanding these gravitational planes, the mid-sagittal plane, which you see here and here, and the coronal plane, which we have talked about extensively, that you begin to understand how important it is to oppose gravity efficiently. And during the course of our lifetimes, we need help opposing gravity efficiently. We need therapy of the soft tissues in order to re-lengthen constricted muscles, increase circulation, decrease tension and pain. In the philosophy of neuromuscular therapy, as we analyze the reason for human pain and distortion and poor biomechanics and poor joint performance, we examine thoroughly the function of the soft tissues, as their performance will determine the integrity of joints, how efficiently we oppose gravity. Let's review again the 4 physiological principles upon which neuromuscular therapy is based. First, ischemia, the hyperconstriction of tissues and the lack of blood. Secondly, trigger points, what they are and how they cause referred pain. Thirdly, nerve compression, the compression of nerve fibers by bones and cartilaginous structures, as opposed to nerve entrapment, the role of soft tissues constricting around nerve fibers. And finally, postural distortion. Why we put postural distortion last is probably because it's most important. Postural distortion can cause the formation of trigger points. It can cause ischemia. It can cause nerve entrapment to occur, and it can cause nerve compression to occur. So the 4 physiological principles that we talked about form the basis of analyzing human pain and dysfunction in the human body. There are 2 supporting factors that are also important that we need to mention. And those factors are nutritional support and nutritional supplementation, and secondly, neuro-linguistic programming, the science of self-communication. It's been our experience, for example, that when people are in pain for a long period of time, they often say things like, "I hate my body. I can't stand myself." Those negative affirmations are, to the nervous system, very neuroexciting, and they contribute greatly to the formation of pain and to the perpetuation of pain problems. Nutritional support is extremely important because whenever people are in pain, a portion of our nervous system called the sympathetic nervous system is extremely excited. In the second hour of this program, we will discuss the role of the sympathetics and the parasympathetics in producing poor digestive performance. We'll also discuss the role of pain and what pain does in absorption and assimilation of nutrition. So for the second hour of our tape, we will be looking at further neurological laws that can be found in Dorland's Medical Dictionary or Stedman's Medical Dictionary, because the laws upon which neuromuscular therapy are based upon the laws of the universe. And what we have done in this first hour is examine some of the laws of the universe that determine human structure and function.